Good morning, everyone. Bonjour tout le monde. Welcome to this morning's roundtable with Green Party Leader Annamie Paul. Ms. Paul is joined today by experts and advocates Dr. Abdou Sharkawi, Dr. Caroline Collane, Dr. Zain Shagla, and Sophia Ikura. Bienvenue à la discussion table ronde de ce matin avec Annamie Paul, chef du Parti Vert. Madame Paul est rejointe aujourd'hui par des experts et des militantes, Dr. Abdou Sharkawi, Dr. Caroline Collane, Dr. Zain Shagla et Sophia Ikura. Merci, ça va commencer maintenant. Now it will begin.
Good morning, everyone. Bonjour tout le monde. Merci d'être avec nous ce matin. Thank you so much for being with us this morning. And the very biggest thank to these four incredibly busy people, particularly at this moment, for taking the time to be with us. I'm incredibly grateful for that. For those of you who have joined us before, you know that the intention is to leave as much time as possible for our panelists to share their view from the ground, to share their recommendations about where we need to go next. And so we're going to turn it over as quickly as possible. We are here today to speak about vaccine prioritization. We're here to speak about the people that are being left out, those who are most at risk, not only of serious illness or death themselves, but also of spreading within our communities. And we're here to talk about what needs to happen next. Just in terms of my case, just before we came online, I shared my thanks with all of the panelists for the work that they're doing in trying to make sure that we make this critical pivot, exactly because the people that we are describing when we talk about these low-income essential workers living in neighborhoods with high concentrations of low-income essential workers, that's exactly how I grew up. My grandfather worked cleaning up shop floors. My grandmother was a personal support worker. My mother was a teacher, and we lived in a very small space in an intergenerational household. And there is no way that under the current circumstances, we could have protected ourselves against COVID. And so I mentioned that just to say that these are real stories with real people at the end of them, and the decisions that we make in the coming days have a real impact on not only their lives, but on the community at large. Alors, c'est vraiment un plaisir d'accueillir nos quatre panélistes aujourd'hui. Je vais laisser le maximum de temps à eux pour partager leurs expériences, pour partager leurs recommandations, exactement parce que c'est un moment d'urgence. C'est un moment où si on ne fait pas les bons choix, il y aura beaucoup de personnes partout au Canada qui seront en risque, qui mettront leur communauté aussi en risque et le public en général en risque. Moi, j'ai grandi dans une famille multigénérationnelle avec des travailleurs essentiels qui n'avaient pas de choix que d'aller travailler chaque jour. Alors, je sais très bien qu'il y a des conséquences réelles et humaines si on n'agit pas. You know, just as someone who has been through this, along with some of the panelists that we have today with respect to long-term care and the mistakes we made there, you know, I had this terrible feeling of deja vu. And so we're going to try to do some work today and hope that the messages are received where they need to be. And without anything more, I just want to ask each of our panelists if they could kindly introduce themselves. And then we're going to ask them to share a little bit about, we have two panelists who participated in very important studies, recently published very important studies on how the new variants are impacting low-income essential workers in particular. And then we're going to enter into a more general discussion. And so if I could first ask Dr. Sharkawi to introduce himself, and if you could just give us, you know, again, your thoughts from let's say from the front line at this moment.
Thank you very much, Right Honorable Madame Paul, and thank you all for inviting me to this very important forum. When I look at this pandemic and where I am and where our healthcare colleagues are, I feel as though we've gone through a transition in terms of susceptible populations, but the principles remain very much the same compared to 1 year ago. The principles really operating here are one of vulnerability, one of what our understanding of the definition of priority is, and what our understanding of the definition of essential is. And those are principles that I think should not change, but they're materializing in a very disturbing way right now. When we finally managed to protect the residents and staff and support workers in long-term care, we managed to hopefully avert more of a disaster in terms of lives lost for that very important part of our population. And we've achieved that at this point in time. But related to the evolution of these unfortunate variants of concern that strike a very different level of intensity and spread and severity within our population, we have spawned a completely new population of susceptible peoples. And those are the people that can't afford to stay home, that have difficulty being able to distance from contacts of COVID-19 because they have fewer supports and resources that allow them to get tested, that allow them to take time off from work to look after themselves, and frankly, that even provide for proper safety policies to be enacted in their workplace with respect to proper PPE, etc. And the net result of that is instead of 85-year-olds from nursing homes that are ending up in our hospitals and in ICUs, we're seeing 35-year-olds who drive Ubers or Lyfts or are cab drivers or work in processing plants, or more recently, we're even seeing teachers. And this is not something that we can continue to ignore. We need to recognize that these individuals provide truly an essential role for our society, both economically and otherwise. And we need to value them and recognize that they are continuing to drive the spread of this disease in our community. And I think many of my colleagues will agree that right now this wave stands to be the most devastating of all, simply by virtue of the fact that that specter of vulnerability has now stretched. It has now stretched to people who are younger, who are healthier, but by virtue of the high risk exposure they have been put in because of their work circumstances and their social circumstances and the communities that they live in, they are disadvantaged very, very unfairly. And this is the time, I think, to advocate with every possible measure that we can to address this, to reach these individuals in their communities, to provide paid sick leave for them so that they have an opportunity not only to take time off if they are sick, but to get tested, to get vaccinated. We have to provide them with every possible opportunity to know that they should not be making a decision between putting food on the table, paying rent, keeping a roof over their head for multiple people in their household, and surviving. It's time to do that. I hope we can galvanize our efforts and our resources to make sure that our elected officials and policymakers make this the new priority. Let's learn from the lessons in long-term care not to be laggard, not to devalue or diminish the role and importance of a valuable part of our population. Thank you.
Thank you so much, Dr. Sharkawi. Dr. Collin, you are out on the West Coast in British Columbia, and you have, I don't know if this study is out or if it's still at the pre-study phase, but if you can just share the experience out in BC, what you're seeing, and also just introduce yourself.
Yeah, good morning. Thank you so much for having me. And I won't repeat what Dr. Sharkawi has said because it's so eloquently put and so clear. So I'll try to just add to it. So yeah, I'm in BC and I'm an infectious disease modeler. I'm a professor and Canada 150 research chair at Simon Fraser University. And through the pandemic, I've been working with public health agencies and also in my own research on modeling questions. And we started looking at the question of vaccine prioritization because vaccines really can do two things. They can protect from severe outcomes or severe disease or symptomatic disease if you get sick. But they can also prevent you from getting COVID in the first place. And early on, I think we designed vaccine rollout strategies that really just took the risk that we saw of who has the most severe and the most, terrible and tragic outcome if they do get infected with COVID. And that's really clearly the very elderly. And we started, I think, completely rightly with long-term care, where we had seen such tragedies that we were not able to prevent before vaccination. And that even outside of long-term care, the risk of hospitalization or intensive care need or death goes up very steeply with age if you get exposed. But what we realized as soon as larger populations started using the vaccines was that, as you might hope, vaccines can prevent you from getting infected in the first place, as well as just preventing you from feeling sick or needing hospitalization or having a bad outcome if you do get infected. And of course, people don't get infected at random, and we're not all equally likely to be infected. Some people are much more at risk of being exposed than others. And if we can prevent someone who's at risk of being exposed from getting infected, we prevent the infections for their contacts, their communities, their workplaces. We prevent more infections than we protect with one vaccine. So we used mathematical modeling to explore this, because modeling is really the tool that allows you to integrate lots of different kinds of information and see how it plays out. Models aren't crystal balls. They won't tell you the future. If you have a crystal ball, I would encourage you to, and it works, to use that instead. That's fair enough. But I think models are the best way to explore the relationship between individual effects, protecting one person, and the population level effect, protecting their community and their family and their workplace and the workplaces and communities of their contacts and onward out into the rest of society. So what we found with models, you can use simple models or complicated models or any of the models, is that right now in Canada, because not everyone is going to be exposed, we have exposed a very small portion of our population. It's actually much better to take into account preventing exposure, and you can prevent more deaths and more hospitalizations and more infections by focusing on and prioritizing those people who are at risk of exposure and at risk of transmission. So we started doing that. I think BC CDC and the BC government announced that they are going to prioritize high contact workers. I don't know how it's changing with the news about AstraZeneca, but I think it's incredibly positive. It's incredibly proactive, and looking forward to discussing it with you guys today.
Thank you very much for that. And Dr. Chagla, I like data very, very much. And I've read your report, and thank you very much for it. If you can just introduce yourself and share some of your findings.
Yeah, absolutely. So my name is Zane Chagla. I'm an infectious disease physician at St. Joe's in Hamilton, and infection control director at that same institution and a few other hospitals across the region. There are two big studies that I think really highlight this issue that we've been looking at, particularly in Toronto and Peel region. One was published by a couple of colleagues, in a couple of months ago, and really this methodology was breaking Toronto and Peel up into small segments of about 400 to 700 individuals, and then looking at census data in terms of percentage of essential workers within those communities, manufacturing, retail, travel, and transport. And a number of the industries where we know people can't work from home. And so we broke Toronto and Peel up into these little segments, and we broke those segments up into ones that were low percentage of essential workers, medium, and high. And so the first study took a look at what happened to these people during periods of restrictions, and essentially during what we thought was the second wave in Ontario, from September really onwards to about February. And it was very apparent that the group that could not work from home, that the neighborhoods of essential workers saw a disproportionate number of cases as compared to neighborhoods that had less essential workers within them, but unfortunately saw a disproportionate number of deaths in those neighborhoods as well. So this is not just, healthy people getting mildly ill and transmitting disease. These are families and individuals that are losing family members because of COVID-19 and the circumstances they are played in. And so that data was powerful. A couple of the authors are very close. And so we sat down and said, listen, we now have these variants of concern. We, as Dr. Sharkawi had mentioned, are concerns, obviously, of the vulnerability of these settings driving further. But from a scientific standpoint, it's an interesting validation of if you introduce COVID into Canada, or you introduce a new strain that's trackable into Canada, where it's going to go first, because that really does suggest what those vulnerabilities are. This is, B117, the strain, the variant that was first described in the UK, was not in Canada in January, and now becomes, the most representative sample of our isolates in Ontario as of about 2 weeks ago. And so where it transmits really does tell you where those transmission dynamics of COVID-19 are occurring. And it wasn't a surprise. We took that data again, analyzed it by neighborhood, went down again to see who is getting COVID-19, and very close correlates with the same neighborhoods of essential workers, where their growth from February, where we started universal testing for variants of concern, to March was 50% over that period, as compared to 18% in neighborhoods with low levels of essential workers. 2.5 times higher growth in neighborhoods that had essential workers within them. And again, re-emphasizing, this was not, this is new to Canada. This is new during that time. Variants weren't in essential workers in January. They were imported via travel, and they spread into essential workers essentially during that time. I think it's just another evidence. Yes, there's the vulnerability. It makes these settings even more vulnerable for transmission. But as much as we say this is variant-driven concerns in this population, these are concerns that existed prior to the variants. The variants make them even more vulnerable in those settings. And so again, calling for mass vaccinations in that area, but also recognizing that, there are vulnerabilities in terms of people getting to work in those settings, particularly needing to carpool in public transit, people having access to testing in those settings, people, again, being afforded the privilege to stay at home if they are feeling symptoms and go through the diagnostic workup without feeling financial constraints. And I think that was what unfortunately led to so much of this in December and January. And again, going into the future, as we know, this third wave is really being driven by this population that we put at risk, and our duty and our responsibility. And even as a society, as we talk about things like lockdowns, if we're not concentrating resources into this population, we're going to be left with the same problem in a month, 2 months, 3 months, 4 months, 5 months, even when vaccines get out there.
Mm-hmm. Thank you so much. Excuse me, Ms. Okura, you have done quite a bit of work on health disparities, and just maybe picking up on one of the last points that Dr. Chagla made. Please introduce yourself, but then also talk about what the trajectory has been for low income, racialized, marginalized communities with high concentration of low income workers. What are the health disparities that you had seen at the beginning of the pandemic? What are the ones that you're seeing now? I have many more questions.
Yeah.
But I guess we'll start.
That's okay. Thanks very much. Hi, I'm Sophia Kern. I'm the Executive Director of Health Common Solutions Lab out of Sinai Health System. We're a small health and social innovation lab. So we've been working really actively with some of the hardest hit communities in Ontario. largely located around the Toronto and GTA area since May. And we started in that community just by interviewing about 120 residents and staff, sort of just really trying to understand the experiences that were driving what we were seeing in the data around the high rates of transmission in these communities. And I think it's much better understood now than it was then. That people, because of their circumstances related to dense housing, to having to continue to go to work, to continue to get on transit, were having many risks, many points of exposure. But in addition to that, there was a lot of fear in the community because the impact of COVID is so disproportionate. It's not just the health impacts, but it's also housing instability and food insecurity, and as a consequence, a lot of shame kind of attached with the possibility of getting COVID. So even though people were doing their best, they were protecting themselves, wearing masks, social distancing, they were still seeing transmission. You know, they had to continue to go to work, so they're putting their heads down and just hoping for the best. So what was revealed to us through these interviews and then working with a few of these community leaders was what were some of the interventions that might help to interrupt those patterns. And I think we're seeing, of course, everything is a bit of a pattern. We're seeing the same pattern of lack of access with the vaccines as we were seeing with testing at the beginning. And so one of the major options was, or opportunities was, to bring testing much closer to the community, but then to socialize it through trusted networks. So many people were afraid to be seen standing in line for a test because they didn't want to have COVID sort of attributed to their household. And they were fearful of the test itself. And of course, they needed to be reassured that in the event that they had to stay home, that there would be emergency financial supports and other supports that would really allow them to remain in place. And the process or mechanism to do that was using existing channels and working with outreach workers who are hired from the community, know the community, were well recognized. I think many of those same mechanisms for improving access to the vaccine are going to be critical here. And I think it's really exciting to see the emerging science from Dr. Collane's study, which is basically showing us that some of the vaccination strategies that are focusing on hotspots are outpacing a more per capita kind of approach, even with age and geographic focus. And so I think that's something we need to begin to trust. It's a relatively new message, but the idea that we can achieve some herd immunity indirectly is going to be something that will be very important to this policy change going forward. I think there are three major shifts that need to happen on the policy side of things. Right now, we have, at least in Ontario, a vaccine allocation strategy that is essentially per capita. It's an equal, not equitable kind of approach. And so in order to address what we are seeing in the data right now, which is a very disproportionate impact on essential workers and their families, we would have to shift a portion of that allocation. New vaccine coming online would need to go to the highest risk FSAs. And you can identify those high risk FSAs by looking at both transmission rates and also, I think, low income and racialization in communities. So those are the things that we know make these populations particularly vulnerable. So that's a big shift. And I think it sounds straightforward, but the reality is Canadians need to really embrace what that means, which is for a period of time, you may see less supply in communities where there is less transmission. And more supply going there. But there's also, I think, two other elements that need to be built out if that strategy is to be successful. Access in particular. So I spent some time, because we train community ambassadors, just spent some time knocking on doors in senior social housing buildings because I wanted to understand what that interaction looked like. And what I found interesting was at that point a couple of weeks ago, Ontario had stalled out at 70% uptake of the vaccine in the 80+ category. But when knocking on doors and speaking with seniors in these buildings, you know, I had an over 90% acceptance rate of, yes, I'd be happy to sign up. The vaccine team is coming through. Consistently, what they told me was, They needed help with the form. So there was either literacy or language barriers. And also they just didn't know how they were going to get there. You know, they live in social housing. The mass vaccination clinics are a bus ride away. They talked about the long walks and having to stand for long periods of time. So the mobile vaccination strategy brings a team into a building. They vaccinate everybody on the floor. Everybody sits in a chair in their doorway and they're observed for 15 minutes and then it's done. It's a highly accessible way for addressing, I think, vulnerability and fragility in seniors, but it's also, I think, a path for understanding that different populations require different approaches. So the essential worker population may need to have a clinic that's a little bit more local to them. And while it can still be at a central location, off hours will be important. Certainly release from employer time with paid coverage is also critical. So there are, I think, design features for reaching different vulnerable populations in these communities that we need to build in. And we have lots of success that we can build off of. So the province invested in 16 high priority communities in Ontario. Each one of those received money for outreach workers. They also received funds for bringing the services much more locally and also for wraparound service. And I think we need to build off of the lessons there. In a short period of time, 2.5 months, there were over 1,000 outreach workers hired for those communities. They had over 80,000 touch points with individuals. And the testing rates went from, I think the last I saw, around 800,000 tests that were administered in these communities that hadn't been happening beforehand. So bringing things more local and making them much more accessible is critical. And then the last thing that I'll say is that we understand that right now it's a logistical challenge getting the vaccine to the right people. But at some point, I think we're going to hit a wall of trust. And the necessity to build trust in these communities is very important. I think people will look at the vaccine and it creates a lot of dissonance for them. Why was it developed so quickly? What does it mean? Why are there 3? How are they different? They have lots and lots of questions. And unless we create many opportunities for their questions to be answered, we're going to see that at some point we're going to start to hit maybe 50% coverage and then people will not take it. So we need to focus on how governments can build trust in these communities. And what they're looking for is a sustained commitment. We're here now. We need you to do this. There is a reciprocal ask that we're making. So we're asking you to take the vaccine. We're also asking you to continue to work. What comes with that has to be a commitment to remain in those communities and to be committed to their health longer term.
Thank you so much for that. And just now opening it up to all of you and picking up on some of the themes, I think drilling down a little bit, you know, there has been some talk of focusing on the workplaces of low income and essential workers. Is that enough? I have, you know, the NACI guidelines and what I've read in your reports and your work is that there needs to be a focus on the neighborhoods as well, the neighborhoods that these low income essential workers live in. Can you explain why? I see a lot of heads nodding about that. So I would be grateful if you could explain why. Why is it important not only to vaccinate in those workplaces, but also to vaccinate the larger neighborhood, the adults in these neighborhoods as well? And I'm just going to throw it out to all of you, and feel free to jump in.
I mean, I can start. I think, you know, what we know from some of the data is that many workers travel over an hour to get to their place of employment. So they may be coming from many different places. I think you actually need to have both concurrent strategies. You need to have an employer-driven one where employers are on the hook to a degree for organizing logistics of mass vaccination for their employees and their families. But it's also really important to recognize that in these communities, many people live in multi-generational households. So if you just go to their workplace, they're less mobile, like older parent may not get there. And so I think, you know, the best way to get coverage if you really want to reach the essential worker population is to go to both places. And I think that, you know, there are essential workers, but there are also other vulnerable people who live in these low income communities who, just by virtue of the fact that there's lots of COVID that has been circulating there, are also getting infected. So I think both are critical.
Yeah, I mean, I would reiterate that, right? I mean, there's multiple inputs into this, and it's not just that workplaces, they have transmission, but it's not that they come there miraculously. It is the communities they live in that are so interlinked to the workplaces, right? People carpool into work together. There is an exposure risk there that the workplace can't prevent necessarily, but still deals with it. There's unfortunately school transmission that is probably also seeping into workplaces, and then leading to further transmission down that pathway, right? And I think we heard this story this weekend of an individual that was a family member of a worker that got COVID-19, that was vulnerable, that unfortunately passed away from complications. And so from the practical standpoint, those cycles are ongoing. Yes, you can work on the one piece of it at the workplace, but it doesn't kill the cycle that's happening in the community. Number two is, vaccination, a single dose strategy, which we've kind of pivoted to, it's not perfect. And so, you still create risks at home from vaccination. There is a 30% reduction from a single dose of vaccine for household members based on some of the data that's come out of the London School of Hygiene and Tropical Medicine, but it's not 100%, right? And again, you have to hit that vulnerability in the community. And I think from a practical standpoint, yes, you could go into a place of mass, where there's a mass large workplace like Amazon, but that isn't every essential worker workplace, right? There are workplaces of taxi drivers that are highly mobile populations. There are workplaces of small businesses that are 5 to 10 employees that are still considered essential. And taking the vaccine to them may miss those mobile, those multiple contact opportunities. Creating community opportunities to get vaccinated at least lets people do it on their own accord, lets their family do it, builds trust in those communities too, to get vaccinated. When they see their families getting vaccinated, their neighbors getting vaccinated, people start talking about getting vaccinated. And so, one cannot go without the other. It has to be communities and it has to be workplaces, not just one or the other.
And when Nasi spoke about vaccinating all adults in racialized and marginalized communities, it's for those reasons. That's the idea. Yeah. What if we don't make this pivot? What can we expect? I think this is what people really want to know. What is at stake here? How much time do we have to make this this pivot? And I mean, do you know, as those of you who are modelers on the call, what do the models tell us about the price of inaction going forward?
Yeah, I think it's really important, and it speaks to the previous question. It's much better from the transmission dynamic point of view if we can vaccinate 75% of a community rather than 25% of 3 different communities. Because by getting 75% of that one community, we reach something called herd immunity, where even if the virus comes, it's unlikely to spread much further. So it actually protects everyone. It protects directly the people that we've vaccinated, but indirectly, the parents who live with them, the vulnerable other adults who live near them, the people on the bus, the Uber drivers, the taxi drivers who work in the community, the retail, the whole set. So I think unfortunately the challenge we're going to face if we don't make this pivot is that we will see much, much higher rates of transmission. And we'll do lockdowns and our shutdowns and our stay-at-home orders and our curfews the way we've been doing, throughout the pandemic, and that's costly and it's damaging. We will continue to see rises in hospitalizations and in intensive care, and I think we will see that anyway because we have a kind of a new pandemic, in a way, a variant-driven pandemic that has arrived and established itself in Canada. Or themselves, there are several variants around, and they're more severe and more transmissible. So I think we'll see transmission. If we don't do this, we'll see more transmission, because doing this is the best tool that we have right now for stopping transmission. We're not rolling out twice weekly rapid tests in all the workplaces. We're not rolling out apps and COVID zero strategies, the other things people have advocated for. Vaccines are the best tool that we have. And if we don't use them as effectively as possible, we're wasting an opportunity, and we will see the costs of the measures we have to take to deal with it. I also want to say, the more we lock down or rely on social distancing, that protects preferentially the people who can stay at home, order their groceries, hunker down and batten down the hatches and keep their kids at home from school without negative consequences. And that means that will concentrate the remaining risk even more among these vulnerable communities who have to work at work. And so I think we will also see an increase in that unfairness, that inequity, if we continue to rely on really the blunt instrument of population level lockdowns as our main tool to combat COVID.
There seems to be, so just maybe putting it in plainer terms, it seems that the consensus is that by targeting in this wave as quickly as possible those low income essential workers and the communities within which they live, we're going to be making the best use of the vaccine supply we have available to us, and that is our best tool.
Exactly.
Is that a good summary?
Yeah.
Yeah, go ahead.
Okay, so let's imagine you are not a vulnerable essential worker, and let's say you're in the 60s age group. And I'll put it this way: what is better than getting a vaccine in 6 weeks' time? Well, one thing that's better is getting a vaccine in 8 weeks' time, but having a much lower risk of exposure for those 8 weeks because we've protected the people who are at risk of exposure and transmission. So even for people who are not essential workers, this is actually, it turns out to be better because it reduces their risk too. So it's not a trade-off of, oh no, I don't want to give up my vaccine in 6 weeks for a vaccine in 8 weeks. You do actually, because you reduce the risk of exposure in the meantime.
Can I just, our time's running short, and I'm going to ask a question, and then as you answer it, all of you just pack in whatever last thoughts you have. It seems clear that there is a public education component to this, because I'm picking up on what you said, Ms. Ukura, and has been touched upon by all of you, which is that this requires a major pivot and rethink of the strategy, one that seems on the face of it to be the fairest, which is, per capita approach, same amount for everyone by age, everyone of a certain age. If we are to pivot to this, given that you've all said that this is the most efficient, effective strategy that we can adopt right now, and the consequences of not adopting it are quite dire, how do we communicate that? And I know again, you're all scientists, but also public policy people as well. How do we communicate that to the public? What is the message, as simply as possible, that we can give to give our politicians the space to be able to make this change? I know that it's a challenge, but I'm just wondering if you could share your thoughts on that, and then any concluding thoughts that you have. And I'll start with Ms. Ukura, and then we'll go to Dr. Chagla and finish with Dr. Collin.
Okay, well, let me give it a shot. I think that the answer is that paying attention to the emerging data around not only who is being impacted by this, so the fact that we have really been able to lock down and remain relatively safe. The majority of the country has been on the backs of people who have continued to go to work. And we need to recognize that there's a reciprocal relationship here where we have to, we rely on those folks to continue to work so that we can stay home. What we need to do is also find ways to protect them in meaningful policy. And so what that looks like in this moment is not only the right thing to do is to shift from a per capita vaccination strategy, but also the smart thing to do to shift to a at-risk neighborhoods most exposed, getting the vaccine first, everybody in those communities, no restrictions, ensuring that those who need it can receive it. It's the right thing to do. It's a smart thing to do. It looks like a very Canadian way to go.
Thank you very much. Dr. Chagla?
Yeah, I mean, I would re-echo that statement, right? I mean, there are Canadians and Ontarians that are fed up and sick of this pandemic. There is data here suggesting what the optimal approach is. There is data here to suggest how we can use vaccines to get us out of this mess for the foreseeable future. There was nothing harmful about going to an older approach, especially in long-term care early, knowing that that was a disproportionately hit population. But we're in another phase of this pandemic. Those institutional centers are protected, but we are in a phase where uncontrolled community transmission is leading to hospitalizations, is leading to scarce ICU resources, is really leading to that healthcare apocalypse that we thought was going to happen at the very beginning of this pandemic. And without necessarily being guided by data-driven to where the gas is fueling the fires of COVID-19 transmission in the community, we're going to be left with vaccines, lockdowns, and many other interventions for the foreseeable future. The other part is this is a population that we have to talk for. It is not a population that has a big union, that is organized, that is, front and center, which is vocal. We are finally having the conversations about this population now because it is such a heterogeneous population that is more concerned about putting food on the table and dealing with life in the pandemic as compared to when my time comes for vaccine and how I get there. And so we as a community need to speak for that community, need to emphasize their need for vaccines amongst the other bundle of things, because again, I will really emphasize the vaccine pivot will not take effects in that community, even if we were to do it today for 2 to 4 weeks. We still need to talk about safety for that community, transit safety for that community, workplace safety for that community, getting every worker that can work from home in some of those semi-essential networks to work from home, and really understanding that financial supports for this setting, regardless of what goes on for the next 4 to 6 weeks, is going to be more essential than anything else in this pandemic. And really, protecting those communities, making sure that they can make the appropriate decisions, but also protect the rest of us. And herd immunity, as we talked about, is incredibly powerful if we get to the right levels. Chains of transmission ends, and so we should be driving this based on the data that's out there, as opposed to necessarily just the loudest voices out there.
Thank you very much, Dr. Colleen.
Yeah, I would just add to that to say, I think looking at data is right. I think expressing that this connects with how best to protect our whole society, and also connects with our values as Canadians and what we try to achieve and should be trying to achieve. It makes the most effective use of a very scarce resource in Canada, namely vaccination. And I think in terms of, if you want to advocate for this for your own networks, I would really connect the data to the stories. So we have the data that are showing these are at-risk individuals. We should be, public health could be putting out, these are transmission chains that we saw. Fraser Health did some really good ones earlier on about someone went to a wedding and they weren't sick, but they were infectious. And here's what happened. And it cascades down through the context and their families and how many people had to stay home. We could be telling those stories, and people in communities with essential workers could be telling their own stories. And I think that would complement the data side and the modeling side, and hopefully we'll be able to get the message across.
Absolutely, and that is exactly why I am sharing my family story. I have the platform to do it, and I know exactly what this looks like. My grandmother was a nurse's aide, had no access to any paid sick leave, went to work literally with a broken back for years, and so would never have stayed home. She didn't drive, she didn't have a car, she took public transit. And then when she came home to another essential worker and the three of us there in a 1-bedroom apartment, there simply would have been no possibility of protecting or preventing the spread. And then we would have carried that out into the community. And so that's really what it looks like. And those are the stories, hopefully, if we share them, we'll make the breakthrough, as you said. And I want to thank you both so much for being here, to Dr. Chakari and Dr. Chagla, who I know had to so much for being with us. Thank you so much for your work, your research, your advocacy. Merci d'être ici avec nous aujourd'hui pour vos recherches et vos recommandations. On espère qu'il y aura l'action immédiate pour protéger les gens le plus au risque, mais aussi la communauté en général du risque. Nous avons pas assez de vaccins en ce moment pour tout le monde, alors il faut les utiliser de manière efficace pour protéger les gens. Alors, c'est ça le défi en ce moment. Et je remercie nos panélistes d'être ici avec nous. Thank you so much to everyone who joined us today for this roundtable's emergency forum, I consider it to be. And we look forward to doing our part to push for action. We continue to advocate for action alongside those health experts and public policy and community activists who have made this call. Thank you so much. And with that, I'll pass it back to Rosie. Rosie.
Thank you so much. We're now going to end the Facebook, but please stay on with us if the media have some questions. On va arrêter le Facebook Live. Alors, on va commencer avec les questions. Une question, puis un suivi s'il y a des questions. We'll start with one question, one follow-up. Are there any questions, please? Vous pouvez utiliser la fonction de lever la main si vous voulez poser une question. Please use the raised hand feature if you wish to ask a question. Okay. No questions. Il n'y a pas de...
Oh, it looks like there's...
Allez-y, Geneviève. Merci.
Oui, bonjour. Enchantée, Geneviève Normand de Radio-Canada. Ma question s'adresse à vous, Madame Paul. J'aimerais que vous fassiez, d'abord peut-être une introduction en français sur la nécessité, parce que c'est ce que je comprends à partir du point de vue des panélistes, de changer l'approche, changer la stratégie, de la faire passer, dans le fond, d'une campagne de vaccination qui cible davantage les personnes les plus âgées, à vraiment faire comme un 180 degrés, mais à plutôt vacciner les travailleurs essentiels et les populations, les communautés à faible revenu. C'est ça que je comprends?
Oui, exactement. C'est exactement ça. Et en fait, c'est pas tout à fait... c'est un pivot de la stratégie actuelle, mais c'est une stratégie qui respecte les recommandations qui existent depuis des mois. La recommandation était toujours de vacciner les adultes qui vivent dans des communautés marginalisées, fort touchées par les taux élevés d'infection de COVID, du virus du COVID. Alors, le problème, c'est qu'il y a une recommandation, un conseil qui n'est pas respecté en ce moment et on voit l'impact. Le fait que c'est beaucoup plus efficace de vacciner les adultes dans ces communautés avec des travailleurs essentiels de faible revenu qui n'ont pas de choix que de sortir chaque journée, travailler hors de la maison. C'est beaucoup plus efficace pour abaisser les taux d'infection en général que de vacciner une personne de 60 ans qui travaille chez eux, qui n'ont pas la nécessité de sortir en ce moment. Alors, si on veut protéger la majorité des gens et aussi assurer que les travailleurs essentiels qui sont exposés à le plus de risques d'infection soient protégés, il faut absolument suivre ces consignes et vacciner à tous les adultes dans les communautés marginalisées et racisées fort touchées par l'infection.
Mm-hmm. And I'll switch to English so that the panelists can actually understand my question. I was wondering, so when that decision was made by the provincial governments to vaccinate the older population first, was it a good decision? Because at that point, the variants, and correct me if I'm wrong, but I believe that the variants were not as strong and transmissible throughout, all of the country. So was it a good decision at that point, back in December, to go and vaccinate the 60, 70 years old and older, rather than going from a low income and essential worker perspective? Do you know what I mean?
Yeah, I can comment. I think it was a good idea to vaccinate long-term care first. I think it was also a conservative approach where we didn't know whether the vaccines would prevent infection from happening in the first place. And so if it didn't, then we wouldn't be able to protect people as well. And so we would want to start really with the most vulnerable, and that's the oldest in terms of risk of an outcome if you are exposed. I want to answer your first question in French briefly. So, il y a un risque d'exposition, il y a un autre risque de maladie si vous êtes exposé. Et la protection des travailleurs essentiels avec la vaccination empêche les expositions. Et l'effet, c'est qu'on peut protéger plus d'une personne par dose de vaccin parce qu'on protège les travailleurs essentiels eux-mêmes, mais on protège aussi les communautés au lieu des travailleurs essentiels. Et donc, c'est une manière plus efficace d'utiliser les doses de vaccin. Et c'est pour ça que c'est la prévention des expositions qui est très importante ici.
Et comment, si je peux me permettre une autre question, comment est-ce qu'on règle, par exemple, la problématique, je ne sais pas si vous l'avez vu dans le courant de la fin de semaine, mais ici, dans l'Est du pays, il y avait des plages horaires de gens qui doivent se faire vacciner. Il y a une population entière, les 60 ans et moins, qui attendent un vaccin, et il y a des plages horaires qui n'ont pas été comblées. Comment est-ce qu'on parvient à remédier à ce problème-là? Parce que s'il y a on s'entête à vouloir vacciner les 70 ans et plus, disons, there are spots available for vaccination, mais les gens, ils ne vont pas. Comment est-ce qu'on règle ça?
Oui, ça c'est difficile. C'est que protéger la population entière, c'est mieux. C'est quand même mieux d'avoir une vaccination maintenant. Moi-même, c'est attendre un peu et réduire les expositions pour tout le monde. Donc, même pour moi, si j'ai une vaccination en 5 semaines ou 6 semaines, c'est mieux d'avoir un faible risque dans les prochaines 6 semaines, les prochaines 5 semaines.
Yes, Ms. Curry, you want to add?
Sure, I just wanted to comment on reasons why you might see vaccination spaces going unfilled in the categories that are allowed right now. So I think we have to understand the reasons why people may not be going to mass vaccination clinics. And so those appointments remain unfilled. And there's lots of barriers, I think, that are structural. So, you know, the location, the mass vaccination clinic, transportation there, people are fearful of going to places that look really crowded. They're worried about the long waits. So there are reasons why, you know, you see lower, we've seen lower than expected uptake in the 80 plus, 70 plus categories. And it's not because they don't want the vaccine, it's because they have many barriers to getting there. So the strategy of shifting the allocation has to be paired with bringing the vaccine much more locally than what we have planned, at least in Ontario, and it may be the same in other places. To get mass vaccination and as many vaccinations into arms, we've looked at large mass vaccination clinics as the strategy, and we need to pair that with more mobile teams. So they may be door knocking strategies for frail seniors. You have to go to encampments where there are people who are underhoused and homeless, and smaller local clinics in places like mosques and churches and synagogues. We know that people trust their faith communities. They're very happy to go there. If the imam or the pastor tells them that they feel that it's safe and it's the right thing to do, they're more compelled if they see their peers going. So there's many strategies for increasing both access and tolerance and acceptance. And so I think we have to think about both, because the barriers can be structural or they can be behavioral. And I think in order to achieve what we're hoping is good coverage in these hotspot communities, we're going to need to have all of these components. And so I think we call them multimodal strategies in addition to shifting the distribution. Those things are both important.
Et je voulais juste peut-être souligner que la troisième vague est différente. Que dans les premières deux vagues, oui, c'était les aînés qui étaient le plus au risque, mais maintenant, on voit que le virus que c'est dans les communautés de faible revenu avec les travailleurs essentiels que les gens beaucoup plus jeunes deviennent beaucoup plus malades et le risque est différent maintenant. Alors, c'est pour ça qu'on a besoin de le pivot. Maintenant que nous avons vacciné les gens le plus au risque, les aînés, les résidents dans nos centres de soins de longue durée, il faut maintenant dire quel est le prochain groupe qui a le plus de risque d'infection et aussi de transmettre l'infection. Et ça, c'est les travailleurs et travailleuses dans les emplois essentiels qui habitent dans des quartiers concentrés avec des autres travailleurs et travailleuses comme eux. Et c'est ça maintenant où nous devrons cibler notre approche, cibler les vaccins. Et ce n'est pas uniquement pour les membres de ces communautés. C'est parce que, comme Dr. Colin a dit et Madame Ikura as well, aussi que c'est là où ça ferait le mieux pour toute la communauté d'une approche de santé publique. Et oui, il faut absolument avoir une approche ciblée, mais aussi une approche qui respecte les cultures, les inquiétudes des membres de ces communautés. Oui, ils ont des soucis, il faut avouer, ils ont des soucis à prendre le vaccin. Ça aussi, c'est une des défis.
Mais cette décision-là revient des provinces. C'est pas le gouvernement fédéral qui peut imposer ça. C'est chacune des provinces qui décide de sa stratégie, c'est bien ça?
Oui, bon, à mon avis, c'est le travail de chaque niveau de gouvernement dans une pandémie qui est une crise nationale d'assurer que notre approche soit coordonnée et soit ciblée vers les communautés, les personnes le plus au risque et où ça ferait le mieux pour tout le monde. Alors, nous, on fait l'appel à le Premier ministre, au ministre adjoint, à chaque membre, chaque député au Parlement de contacter les premiers ministres des provinces, de faire la même chose que nos panélistes, de dire qu'il y a un problème, il faut agir et de faire leur mieux comme des avocats pour leur communauté, d'assurer qu'on fait le pivot. Parce que chaque député au Parlement est quelqu'un qui représente une circonscription. Et il y a beaucoup de membres des circonscriptions parmi dans notre pays qui ne sont pas bien protégés aujourd'hui, exactement parce que nous n'avons pas fait le pivot. Le Parti vert a appelé ça fait des mois et des mois pour une approche coordonnée à notre distribution des vaccins, exactement parce que une communauté ici en Ontario est impactée par les décisions d'une communauté en Colombie-Britannique. Alors, malheureusement, nous n'avons pas une stratégie coordonnée dans l'absence d'une stratégie coordonnée, il faut assurer que chaque personne dans une position de pouvoir, avec une voix et une plateforme, l'utilise pour pousser pour le pivot. I think our panelists have to go.
Yes.
Rosie, any other questions?
Yes, I was just going to say some of the panelists have had to go. They thank you so much for being here. And that will conclude, I believe, our questions for today. So this will conclude the roundtable for today. Ceci va conclure la table ronde d'aujourd'hui. Merci à tout le monde. Thank you to everyone for being here.
Merci pour les questions. Merci, Dr. Colleen. Thank you very much.